Hello, everyone, and welcome to another day of the Pandemic, Science and Society. Today, we are going to be talking about treatment and safety, and then we are also going to have a guest in our second hour who will be talking about health disparities and practicing medicine in the age of COVID. So I'm going to go ahead and get started with today's first hour lecture by myself. So I'm going to share my screen here. All right. Hopefully you can all see that. So we're going to talk a little bit today about treatment and safety. And one thing that I want to do during this time is bring together all of the information that you've been learning in this class so far. So we have a few of these hours throughout the course where we have a chance to kind of catch up, synthesize, talk about the things that we've already been talking about, put them into context, and thinking about additional issues related to what hasn't yet been covered. So I'm going to do that today with talking about treatment and safety, particularly as we're now starting to shift a little bit more away from the science behind COVID, starting to look more at treatment and how this is working in communities, and then moving into those aspects of what it looks like in our society. So, of course, we're talking about treatment and safety for SARS-CoV-2 and COVID-19. And I want to say up front that, I think a lot of people have questions about treatments and interventions, because this is something that obviously we're very concerned about so that we can get back to some reasonable normal for our lives, as well as the fact that we hear a lot about it in the news, right? And it's sometimes difficult to know what might be a good treatment and what might not. So I can tell you that right now, at this current point in time, and it's important to specify that because things change constantly within this pandemic, the best intervention that we have for COVID-19 are behavioral strategies that reduce the transmission of the virus. So you may remember Professor Schlatter saying, prevent the possibility. This was a piece of advice from her grandfather, who was a medical doctor. And this applies very much to COVID-19, where our best intervention is trying to prevent the possibility of spreading the virus. And in that same lecture, Professor Achayo said, no single drop of rain ever considers itself the cause of a flood. And she pointed out that each of our individual behaviors compile to cause this catastrophe that has now happened. But rather than thinking of ourselves as a single drop of rain that doesn't make a difference, we can recognize that we do make a difference, and then we can take on the behaviors that help actually improve the situation. And so she said, instead, be that drop of rain that causes the ripple effect of positive behaviors. And I really want to emphasize that throughout this lecture today, that a big part of what we're hoping to do is normalize some of these things that are helping to improve the safety for all of us and for our communities, and make them just a normal way of life, because there's been some issues with being able to do that. But it's also important to realize that as individual drops of rain, there is a lot of individual variation between us. Not everyone has the same possibilities, not everyone has the same experience during this pandemic. And so we need to be aware of that, we need to be thoughtful about it. And as I said at the beginning of this class, we always want to be compassionate, be considerate, and realize that people are dealing with a lot of different issues. So on the first day of this class, I pointed out that some people in the course probably have gotten COVID. Some people have probably experienced racism because of COVID. Some people don't have safe homes. Some people are worried about family members. And I was giving those as examples because in a group of people of this size, the statistical probability of that being the case is pretty high, but in the discussion, in the comments, in the questions, we have seen that in fact that is the case. Students in this class are experiencing those things. So I really want to remind each of you that as you interact with this material and as you interact with each other, you should be doing so professionally. This is a course, so you need to be acting professional in it. And I also really encourage you to show each other compassion and kindness, as so many of our speakers have said. And of course, always be respectful. That's an important part of being part of the campus community. So really remember to treat each other with kindness. This is a hot topic. There's a lot of debate and there's a lot of strong feelings. And it's okay to have all of those, but it's also important that we treat each other with respect and we act professional in this setting. So with all of that in mind, you might be feeling like Amblehead here, who's giving me the side eye and saying like, okay, great, I get it. There are behaviors that I can do to improve this situation, but I'm sick of not seeing my friends and I really want to be able to hang out with them. So can you please just tell me what medicine exists so that I can get back to hanging out with my friends and having a good time, right? I appreciate that. It isn't great when I give a lecture on treatments and safety and the treatment, the medical intervention is change your behaviors, keep your distance, and hopefully one day something more will be available. So I understand that. But the reality is, as so many of our speakers have said, we are still fairly early on in this pandemic. And in terms of being able to come up with treatments, test them, be cautious about the interventions that we're using, it takes time to do those things and to develop those strategies. So, let's see if I can get back to my slides. Here we go. So you will hear about different treatments being tested. There are several that are being tested right now. And I want to point out that these are things that are still being studied. So not only over the course of this class, which is 3 weeks long, but also over the course of the time of the fall semester after this course ends, the information that we have about those different treatments will be changing. You'll be hearing new information. And as we find out more, the take-home message may change. So I think at this point, where we are with having treatments available for COVID is still very much in the study phase where we can't say for certain anything specific about those treatments. And so instead, what I want to do today is to provide you with tools to evaluate the evidence that is coming out and will continue to come out about potential treatment methods. One of the treatments that you may have heard about in the news is hydroxychloroquine. So I think something that might be very useful is for us to walk through an example of the sorts of literature that you may see coming out about a particular treatment and the studies that are done to try and test that treatment. So in this article, they're looking at hydroxychloroquine and azithromycin and how they help patients who have COVID. Now, I want to point out to you that this is a study that as of this morning on Google Scholar was cited by 2,231 other published studies. So this is not some random small comment that I found on the internet. This is a publication in an international journal that has been cited many times. Here's the abstract. Now remember last week, for the first day of class, you were supposed to read a piece that taught you how to interact with scientific literature, right? And I really encourage you, especially if you're looking at the literature, thinking about different treatment options, that you review that piece and think about where to start, what to think critically about. And that's kind of what we're gonna do today. So of course, in that, it tells you to be wary of the abstract, but let's start with the abstract because it summarizes the message that this article is trying to give us. So first at the top here, I think you can see my cursor, you'll see they have some background here. They say that they're testing chloroquine and hydroxychloroquine because it's been found to be effective for treating SARS-CoV-2. Then it goes down into the patients and the methods. So this is a study that was done in France, and it was using people who were confirmed COVID-19 patients in France. It started in early March and went until mid-March. Okay, so early March to mid-March of this year, we've got a study coming out about confirmed COVID patients from France where they're doing this research. You come down here to the results, and you'll see that it says 20 cases were treated in this study and showed a significant reduction of the viral carriage at day 6 post-inclusion compared to controls, and much lower average carrying duration than reported in the literature for untreated patients. Azithromycin added to hydroxychloroquine was significantly more efficient for virus elimination. And so they draw this conclusion. Okay, good. Trying to figure out how to use my mouse within Zoom. They draw this conclusion: despite its small sample size, our survey shows that hydroxychloroquine treatment is significantly associated with viral load reduction / disappearance in COVID-19 patients, and its effect is reinforced by azithromycin. This is important news, right? So here we are in mid-March. At this point, the university's barely shut down, and amazingly, we have a treatment for COVID-19. And so, of course, as we all know and history shows, there were major celebrations, things opened back up. We haven't been locked up since March, not at all, right? That's not what happened. Even though these results suggest that there's great reason to celebrate, we have a treatment that works and we're all good to go. It shouldn't be August 2020 and we're still dealing with this pandemic. That's not what happened. And so what did happen, given how promising this looked? I mean, 20 out of 20 patients, that's pretty good, right? So if we dive into this article more closely, I want to show you the results. So first of all, in the results, which is section 3 of this paper, they show the demographics and clinical presentation. And I'm just double checking that, okay. So they said that we enrolled 36 out of 42 patients meeting the inclusion criteria in the study that had at least 6 days of follow-up at the time of the present analysis. Okay, so they use this word, inclusion criteria. Now that's important. If you're reading a study and you want to understand it better, make sure that you read the methods carefully, because also the methods are where you're going to find certain assumptions that are being made, certain tactics that were used that you may have a critique of. And so it's good to look at the methods closely and to think about how they conducted the study and if you think that was a reliable way to conduct the study. So if we look back at the methods section, which is section 2, here they show the patients, and down in this bottom part, hopefully you can see my cursor, it says patients were excluded if they had a known allergy to hydroxychloroquine or chloroquine. That's important. Don't give patients that have an allergy to a medicine that medicine, or if they had other reasons for not being able to take that medicine. Also, if they were breastfeeding or pregnant, then they were not included in this study. Okay, so that's fine. I'm not pointing this out because there's any issue with them excluding certain people from this study. However, as you continue to read the hundreds and hundreds and thousands of studies that come out about potential treatment for this illness, it's good for you to always be keeping these things in mind, looking back at their methods, looking back at their study population, looking back at how they selected people to be part of their study. And so pay attention to that sort of wording, pay attention to these sections within papers. All right, so they've got these patients that they've enrolled, and then they say that they had a total of 26 patients that received hydroxychloroquine and 16 were control patients. So 26 receiving the treatment, 16 controls. Great. But then they have this sentence that I've underlined in red. 6 hydroxychloroquine treated patients were lost during the follow-up of the survey because of early cessation of treatment. that seems like an important and interesting fact, right? Because potentially those are people who got better and left the study because they were all better. And if so, great, that would add even more strength to the conclusion that they're drawing, which is that this is a good treatment method. All right, so let's keep looking at this. So if we continue on in their results, they say that of those 6 patients who were lost from the study, the reasons are as follows. 3 of the patients were transferred to intensive care units. Okay, so 3 of the patients were lost because they got more seriously ill and went into the ICU. 1 patient died. 1 patient decided to leave the hospital, and 1 patient had nausea and so stopped taking the medicine. Okay, this seems very relevant, right? So these are 6 patients that were not included in this study because they were transferred to the ICU, they died, they left the hospital, or they had side effects that caused them to stop taking the medicine. So the results presented here and thereafter are those of the 36 patients, not the original 26 and 16, but now they've removed those 6 from the 26, and so you have 20 patients that received the treatment because we removed the 6 that left the study, and 16 that were the controls. Now, also importantly, in this results section, they say none of the control patients were lost during follow-ups. So you have 6 individuals that were being treated with hydroxychloroquine that were no longer part of the study because they had to leave for various reasons. And then you have the controls where all of the control subjects remained in the study. That seems important. So let's go back to that conclusion that they drew. So out of these 20 patients, the 20 patients that didn't get so sick they went into the ICU, that didn't get so sick that they died, that didn't have a bad reaction to the hydroxychloroquine, and that didn't leave the hospital when they were being treated, those people, the 20 of them, showed this significant improvement from being on hydroxychloroquine, right? So despite the small sample size, our survey shows that hydroxychloroquine treatment is significantly associated with viral load reduction / disappearance in COVID-19 patients, and its effect is reinforced by azithromycin. I'm trying to keep an eye on the questions as I'm talking about this, just so you know. That's why I keep looking off to the side. So in other words, you have 6 patients, that's 23% of the original treated sample set, not included in the analysis. 3 were admitted to intensive care units, 1 died, 1 discontinued treatment due to side effects, and 1 left the hospital. So those 6 patients were not included in the results of the study. They were not included in that conclusion that this drug worked really well. Okay, that isn't because, it isn't necessarily because these authors are being malicious, right? The way that the study was being conducted, they were taking samples. And it's hard to take a sample from a patient that you're counting as part of a group of people being studied while they're alive if they're dead, if they're in an ICU and intubated and you can't get a sample from them, if they've left the hospital, or of course, if they've stopped taking the treatment, then they wouldn't be included. So it doesn't have to be that the reasons for not including these individuals were in any way meant to mislead us. It is the case that they were not able to get additional samples and therefore had to remove them from the study. Nevertheless, the way that we draw our conclusions need to take into account that additional information. So you have to wonder, would the inclusion of those patients have changed the conclusion of this paper? Would you still say, with 23% not being included in that final analysis, that, and 4 out of those 4 out of the 6 having negative results, would you still come up with this conclusion about how effective and how good this treatment was, right? So other studies have been done on this. These are just two examples from the New England Journal of Medicine and Cell, where they looked at larger cohorts. Of course, many of you are pointing out in the questions section that this is a small sample size. It is a small sample size. Also remember that early on in the pandemic, we were dealing with small sample sizes of people in each new country that it arrived at. So there are some limitations already on the study. But even with that, regardless of whether it's a big study or a small study, you want to be looking at the assumptions they're making, the methods that they're using, and the data that they are choosing or not choosing to include. That's very important. Just as a lot of our speakers have said, you can't just rely on scientific information as if it's complete fact. You have to engage with it and criticize it. So these additional studies, which are larger cohort studies, have shown that they have not found an effect of taking hydroxychloroquine on improvement of patient outcomes. So these are the sorts of studies that you will see coming out and that I encourage you to look closely at, to go back to that piece that I assigned for the first day of class where you think about what to look for in a scientific publication and how to analyze it, and think through what sort of information you're getting, because you don't just want a piece to come out and for you to believe completely in whatever it says. So again, there were issues in this study, not only because they did not include some of the data, which were from these 6 patients, as some of you have pointed out, there's also the small sample size. In addition to that, if you read the methods of this paper, you'll see that there were some issues with recruitment and also with controlling different factors. So for recruitment into a study, the 16 people who were not given hydroxychloroquine were not given hydroxychloroquine because they said they didn't want to take it. That's not normally how a randomized study works. It's not normally just, okay, the people who agree to take it, they end up in one group and the people who don't end up in another. So that's a problem. Also, those people who were not taking hydroxychloroquine, some of them were at a different medical facility. So there's some difference in control of various factors. You want to be thinking about all of these things when you're reading the literature and thinking critically about what you can take away from it. And I will reiterate again, as so many people have done, that we are still early on in this pandemic. Data are still coming out, and we don't know for sure what the answer to any of these questions are yet. But I want you to feel that you can look at the literature and you can critique it and you can digest it and you can try and figure out which pieces you feel more confident in and which ones you think really need a lot more work. So I encourage you to do that. Be a critical thinker. Be active in your engagement with these pieces of information. Read the details, not just the headlines. I think, there's this cultural thing happening, I guess, where people just scroll through headlines and they're not actually getting the details. They're not actually understanding what they're reading. So I encourage you to read the details, try and really understand what's happening in the information that's being put out there. And also, I encourage you to use what you've learned from this class in order to evaluate the information that you're getting from outside sources. We've compiled experts in their fields to talk to you about how you can think critically about the information that you're hearing, how you can try and identify misinformation, and how you can evaluate the information that you're reading. So I encourage you to do that. And also remember that this situation continues to change. It's continuing to develop and we're learning more and more. So it may be the case that there is information that suggests something is very good. And then once we've done more research on it, we've gotten a larger sample size, we've looked at different interactions, we realize maybe it's not as good as we originally thought, or maybe it's better than we originally thought. Ultimately, though, I would say that it can often feel frustrating when information is constantly changing. We talked about this on the first day of class. The mixed messages and the changing messages about masks, for example. It can make you feel like, who can I possibly believe? What's the point? It makes it feel easy to give up, but please don't give up, because there are people working very hard to try and get the information that you need to you and to try and figure out these mysteries, these medical puzzles as they're becoming available to us. So don't give up and try your best to engage with the literature that you can and evaluate it. All right, so that means that what we're left with are these interventions, these behavioral changes, and we've been learning a lot about those in this class, and I want to synthesize what we've learned, some of the big takeaways, just reiterate those things that you can be doing. One of the things that I think has become very apparent as we've talked to all of our speakers is that knowledge is an important tool against COVID-19. For example, on one of the first days of class, we learned about asymptomatic and pre-symptomatic spread of COVID-19 and how that compares to other viruses that we've had outbreaks of in the past. And really understanding that asymptomatic and pre-symptomatic spread are a serious concern for COVID is important in how we interact with each other, how we try and decide what's safe, how we try and identify risk. So the knowledge that you're getting in this course, I hope helps you to evaluate situations differently and can be a tool for you as you move forward in this pandemic. Obviously, you've heard it a million times, and I'll say it again. If you are able to, please wear a mask and make sure that it fits properly. That means actually taking the time to look in the mirror and check how you have it on, check that it's functioning properly and that it's a good fit. Keep your distance. It is still the case that droplets are one of the main ways that this virus is spread. So if you are standing close enough to someone where a droplet from their mouth could land on your eyes or nose or mouth, or that yours could land on theirs, then you need to be concerned. And because of that, you should keep your distance. Also, get outside. Another mode of transmission is aerosol transmission, and it's more of a concern inside than outside. Remember that when we're talking about outside, we want this to be an open area where you have a breeze, where there's the possibility for wind to be helping to get rid of the particles that you're releasing. So get outside, keep your distance, wear your mask. And also wash your hands, because don't forget that another way, albeit a less common way, another way that you can get COVID-19 is through touching the virus and then touching your eyes, your nose, or your mouth, right? So imagine that you're outside, you're doing a great job wearing your mask, staying distant from each other, being out in an open area, but you have something that you're passing back and forth, and then you keep rubbing your eyes or wiping your nose, or reaching into your lip gloss and putting it on your lips. Those are things that will still lead to transmission if you're interacting with someone who has the virus. I think another really important message that has come out of our time in this class is that you should be kind. Remember that not everyone is in the same situation as you. Not everyone has the same advantages potentially. And so try and be kind with each other. Another important message that's come up in multiple lectures is that if you are able to, vote. Some of the decisions about this virus are being made outside of your control, and the way that you can influence those are by voting. This is true at many different levels within our society. So I want to give you an example of a case study of something that's maybe off your radar. If you're not in law, I know some of you are, but if you're not in law, this may be totally off your radar. This is a news story from July 30th about a person who took the Colorado bar exam testing positive for COVID-19 after having been at what they call the contested test. If you weren't following the news of the bar exam this summer, which most of you probably weren't, and I don't blame you, state to state, there was a lot of discussion about this among the legal community about whether to have the in-person bar exam or not. So if you don't know, every year after students graduate from law school, there are two opportunities, they're spaced out about 6 months apart, to pass the bar exam. It's state by state, so each state hosts a bar exam, It's not like the MCAT where you go into a testing center and you do it and you're not around a ton of people. It's an event where they have a specific space where everyone who wants to take the bar for that state so that they can practice law in that state comes to this specific place, takes the exam, and then goes back. They stay there for 2 days. And you can imagine that in the time of this pandemic, that's a bit controversial. So the date of this news story is right around the time of the Missouri bar exam, which was July 28th and 29th. And leading up to that in-person bar exam, there were petitions by students, there were op-eds in the paper, there was a request from the law school deans of all the law schools in the state of Missouri to please not have this in-person bar exam because of the dangers of it. There are alternatives in place, and this is important to know. So for example, the same organization that makes the in-person bar exam made an online exam, and other states, like for example, Illinois, have used this online bar exam. Keep in mind that because you have to take the bar exam in the state where you want to practice law, you can't just take the online bar exam in Illinois because you want to practice in Missouri. You still have to do it where your exam is taking place. And there's also something called diploma privilege, which, for example, Oregon and Washington use. Multiple states have used these different systems, but I just want to give you a few examples. Diploma privilege, which is what the law school deans in Missouri were advocating for, says that students, or so I believe, says that students who have graduated successfully from law school should be admitted to the bar because we're in unprecedented times, as we keep hearing, right? And I think for Missouri, this is particularly important because you have states that are willing to do this and Missouri was not willing to do it, despite the fact that Missouri actually has the lowest standard for passing. So, you know, like the lowest grade you can get and still considered passing, that's Missouri. So states with higher standards were allowing this diploma privilege, but Missouri was not. So they had, of course, a serious review of their plan. They added some additional rooms for test taking, additional site, and said everyone would stay 6 feet away. Of course, if any of you have played around with the indoor aerosol estimator, you know that those 6 feet might not matter. And importantly, they had no testing required before or after, and they had no specialized plan for contact tracing. It was just up to local health departments in the place wherever the infected person ended up after the exam. Okay, that's important. So you had about 700 or so recent law grads traveling from around the state and beyond, anyone who wanted to be a lawyer in Missouri, to take the exam, staying 2 nights at a hotel, being indoors for 8 hours of testing per day. And I know, for example, the largest room they had about 250 people assigned to it. They had to get a waiver from health departments in order to have this large gathering, because it's a large gathering, right? And there are restrictions on large gatherings right now. So even though there were these other options, and the demographic of people who would be participating was largely people who are likely to be asymptomatic carriers, people in their young and mid-20s, they received this waiver. So the question is, when will we ever learn the impact of this event? And the answer is maybe never, right? Because we don't have follow-up testing. We don't have people in place to trace. Obviously, the rates in Missouri have increased since the time of this exam, but there's no one specifically looking at if you can link the increase to people who would have interacted with test takers who may have come into contact with it here. So you have events like this happening that are out of your control, but that are in the control of people who are elected to office. Judges who have retention elections and people who are appointed by your elected officials. And so that's one of the reasons why, and I wanted to clarify this just as an example, of why you hear so many of our speakers talking about voting, because how you want this pandemic to be handled depends on who you vote for, right? And I mean, who you vote for is your choice. There are many state and local people running. I could never possibly tell you who you should vote for, but be keeping that in mind as you're thinking about ways to get out of this pandemic. So again, we've got knowledge of asymptomatic and pre-symptomatic spread. wearing a properly fit mask if you are able, keeping your distance, getting outside, washing your hands, being kind, voting if you're able. And I also want to remind you about the importance of communicating and planning. We are no longer in a situation where we can just do whatever we want without thinking about it. And so I want to remind you of Ann Bullhead here trying to plan her trip outside, and how even though it is so difficult for people to have these conversations about what interactions are going to look like, we have a great group of people here who are all learning this information, and I hope we can become a community of people who work together to normalize these behaviors and make it okay to have these difficult conversations and to create a safe community together. Also, as you've heard from multiple speakers, it's important to test for COVID and to not have stigma around that testing. So we want frequent testing and we want testing without stigma. Now, a lot of you have had questions in the Q&A about this, so I want to dive into this a little bit right now also. So one of the issues that has come up in this class and in the world is the issue of false negatives and false positives in testing. As Dr. Otley said, biomedical tests have false negatives and false positives. That's true. Of all medical tests, we rely on biomedical tests that have false positives and false negatives all the time, because that is something that is part of biomedical testing. Now you add to that the fact that this is a very new virus that we are still learning about. It's new to the medical world and we're still learning a lot about it. So we haven't had time to fully develop the best possible tests like we have with some other things that have gone through multiple iterations, right? So this is complex. We've got biomedical testing that already can have false negatives and false positives. And then we have this added complication of a new virus where we haven't had much time to develop the best possible tests for it. That makes this complicated. That definitely adds to the fact that we should always be using these safety measures. We should remember that we can't fall back on a negative test as a way to say, I'm going to do what I want, I'm negative. And keep in mind that these false negatives are a really big concern. These are a concern in the scientific community and in the medical community. So earlier this month, August 6th of 2020, the New England Journal of Medicine published this piece called False Negative Tests for SARS-CoV-2 Infection, Challenges and Implications. And I want to share with you just a couple of their findings at the end, the major take-home message, not really findings, but the major take-home messages that they have talked about for thinking about moving forward with testing. Okay, so they say, we draw several conclusions. First, diagnostic testing will help in safely opening the country, but only if the tests are highly sensitive and validated under realistic conditions against a clinically meaningful reference standard. Okay, that's tough. Again, we need time to do these things. Second, the FDA should ensure that manufacturers provide details of tests' clinical sensitivity and specificity at the time of market authorization. Tests without such information will have less relevance to patient care. Again, that takes time to develop. Third, measuring test sensitivity. So test sensitivity, what that means is how sensitive is it to detecting the virus? If you're an asymptomatic carrier and you have a viral load that's hovering just below the sensitivity of a test, then you may have a negative test result even though you are actually positive and you are able to spread the virus. So that's what we're talking about when we're talking about sensitivity. How sensitive is it to being able to identify the virus? Measuring test sensitivity in asymptomatic people is an urgent priority. Just as we've heard in this class, asymptomatic spread is a concern. It will also be important to develop methods, like prediction rules, for estimating the pre-test probability of infection, both for asymptomatic and symptomatic people, to allow calculation of post-test probabilities after positive or negative results. Okay, now that's complicated. What that means is that there needs to be some factor that you take into account before you even run the test that lets you try and predict how confident you are in the results of the test. Fourth, negative results, even on a highly sensitive test, cannot rule out infection if the pretest probability is high. So clinicians should not trust unexpected negative results. In other words, assume a negative result is a false negative in a person with typical symptoms and known exposure. What that means is if you go to the hospital presenting with classic COVID symptoms, you have a test and it comes back negative, they're saying that based on that pre-test screening of you having such closely linked symptoms, that should be considered a false negative. It's possible, this is important, it's possible that performing several simultaneous or repeated tests could overcome an individual's test-limited sensitivity. However, such strategies need validation. I feel like these two paragraphs are very well written and very clear for the sort of difficulties that we're trying to overcome with testing, and also shed some light on how we could start to feel better about testing. And particularly as universities are starting to open, I think this last sentence is so key because universities present an opportunity to be doing repeated tests where we try and figure out if repeated testing overcomes the limitations of the testing that we have right now. So again, reiterating that these biomedical tests have false negatives and false positives. The added complication for COVID tests is that they are new and we're still developing them. And so we have to always remember to be practicing those safety measures. We don't know yet the extent of false negatives. We also don't know the extent of false positives. So there is anecdotal evidence about false positives. There's been less written studies on this, but of course you hear stories about somebody who had a positive test and then a negative test. And you know, that's complicated because you don't actually know which test is right at that point. But so all of these things are things that we're still working on. And again, this is still a new virus, but keep in mind that anecdotal evidence is still evidence, but it is not the same as a study in which you gather data from a large cohort and test certain numbers, right? Those are two different types of evidence. All right, so given how controversial the test results are, why should we test? What's the point in that? But remember that these tests can still identify positive cases. And as Dr. Page explained, those positive cases then get passed on to be confirmed. And if you have a confirmed positive case, then you know that you need to be even more careful about your interactions than if you aren't sure if you're positive or not. And so we need to test so that those positive, clearly positive cases can be identified and handled. And because exactly as that last paper was talking about, more testing will lead to more effective and reliable testing in the future. In addition, I think the reason that knowing you have a positive test is important is because, as Dr. Page said, good testing practices also include providing the resources you need to do any isolation or quarantine that you need to do. And I'm sure you've heard WashU talking about this. That's something that they're thinking about and wanting to make sure that they create a situation in which students who test positive have a place that they can go, they have their needs met, so that they can actively try and reduce transmission of the virus. Now, because it's good to be testing frequently, to normalize it, I want the conversation to be around normalizing testing, making it very accessible. Certain studies have come out trying to model how often we will need to test. So this is just one example. There have been a couple recently this month. This one is the assessment of SARS-CoV-2 strategies to permit the safe reopening of college campuses in the United States. That sounds very relevant to all of you right now. And what they determine, and by the way, I should point out, they use the term screening here, even though they're talking about testing. So if you look at this article, you will see that by CoV-2 screening, they are actually talking about testing, which is different than screening for symptoms, right? So I want to clarify that. They recommend that testing ideally be done every 2 days. So given this article and some other articles that have come out, you see universities that are starting to reopen, implementing these plans. So of course, WashU has postponed their opening dates, so we're still developing those strategies. But we can look at peer institutions like Harvard here. Their strategy is, you can see down at the bottom, hopefully you can see my cursor, for students that are living on campus in the dorms or in housing, they get 3 days a week of testing. For students who live off campus but are required to be on campus for work or in person more than 1 day per week, they have 2 days a week of testing. And for students who live off campus but are required to be on campus for work or in-person activities more than 1 day a week, they have 1 day a week of testing. So another source where I saw Harvard had this posted, it was basically, if you live on campus, you do 3 days of testing a week. And if you are faculty, staff, student that lives off campus, then you have the option of 1 day a week of testing. I just heard a story on NPR this morning. Northeastern University has a similar 3 day a week plan for their testing as well. So these are the sorts of strategies that we'll see rolling out as campuses are reopening. And I so love this picture of Dr. Page getting her test, because I think that it does exactly what we want to do here, which is normalize testing, have it be a positive thing, don't have stigma applied to it. So normalize testing, reduce stigma. If you have a positive test, or if you want to get a test, you shouldn't feel like you have done something wrong. And as a community, particularly with a class this size, I think that we can really work on destigmatizing testing and illness. And I want us all to do that together. So I want to just give you an example of my experience with testing based on the lectures that we've had up to now. I think this is relevant. So I'm showing you this elephant from Uganda because, as you know, I spend a lot of time in Uganda. And after my first time in Uganda, I had spent a lot of time in the forest. You know, you run around in the forest, you get bloody. You're out there working with other people who maybe are bleeding also, to be totally honest. I remember one time very clearly looking at my hand and thinking, oh shoot, I'm bleeding. And I wiped it and realized, oh, that's not my blood. That's somebody else's blood that I just got on me. And in Uganda, you know, it's been an interesting place for dealing with HIV. There's a lot of interesting work, both from the global perspective and local perspective, on how HIV has been handled there. So when you're in Uganda, people talk a lot about HIV. And that was on my mind as I was there, right? And as I was having these situations where suddenly I had blood on me that I didn't know whose it was. And I later learned that actually blood-to-blood contact you have a very low rate of getting HIV. But I didn't know that at the time. And so I came back from Uganda for the first time, and I had been other places, but this was my first time coming back from Uganda. I went to the doctor and I asked for an HIV test because that seemed like the responsible thing to do. And I got questioned a lot about what sort of behaviors I was doing there that I needed an HIV test. And I also had to sign a paper. So this is more than 10 years ago. So this is prior to our insurance and healthcare changing in this country. And prior to that, if you wanted an HIV test, I was told I had to sign a paper acknowledging that my healthcare provider could either deny me coverage or increase my rates because I wanted this test. Okay, now you're talking about stigma. Trust me, this was not a positive experience. There was a lot of stigma associated with it. And some of my friends said, like, why would you go to your doctor to get an HIV test? Go to an anonymous clinic. And I was thinking like, oh, okay, I never thought of that. But also, should I have to go do something anonymously because I'm trying to be responsible? That doesn't seem like the right message. And I want to orient myself a little bit in this conversation because, you know, I was raised by a single mom who didn't have a college education. I spent a lot of time with my grandparents who also did not have college educations. I'm from a Slovak Catholic family. I was very religious growing up. I still go to mass with my mom when I'm with her, not during COVID. But, you know, the idea of something being stigmatized was not something my family ever talked about. There are a lot of things that I have learned and am continuing to learn since I went to college, since I went to grad school, now that I'm a faculty member. I didn't know these things growing up. So even in my mid-20s, when I was first faced with this doctor judging me, I felt really self-conscious about it. I felt really bad about it. And now I know that it should not be like that. And I don't want it to be like that for any of you, because this is not how we should approach something that should be normalized, that should be positive, that is good for all of us. And I actually recently had a similar experience trying to get a COVID test. And again, it was a very negative experience. I felt intimidated for wanting a test. These are not the sort of interactions that we should be having. And instead, as a community, we should try and normalize these interactions and these requests for tests. One thing that really helped me following the COVID testing attempt was having people say to me, like, I'm really sorry that happened to you, and that shouldn't happen. And I want you all to know that also. If you've had a negative experience, I am telling you, I am sorry that happened, and that shouldn't happen. And I hope that at least within our community, we can be compassionate and supportive of each other as we go through this process. And yes, it still remains that the people in charge who are proliferating the stigma need to listen to Shanti Parik's lecture and need to engage with all of the information about how to make testing more positive. That still remains, but at least we can control what we do together within this class. And so I want to encourage you all, again, to show kindness. So to wrap up this treatment and safety portion of our lecture, remember to be following those safety guidelines, to show each other kindness, and be practical. There's no way around the fact that you can't have a rager right now. It just, parties are complicated. And having a get together outside is great, provided that you plan it in a way where people aren't all needing to go inside to use the restroom, for example, or aren't all grabbing drinks out of a common cooler and then sticking them on their mouth. Don't put anything on your mouth. There are ways to socialize, but there are also things that cannot happen right now in a safe way, and you just have to accept that. And we'll all be better off when we do. So with that, I still have a few minutes for questions. So I'm gonna dive in, though you have over 300 questions here. So I don't know how many I'm going to get to before our next speaker. One of them is, why would someone be unable to wear a mask? And I'm glad that you asked that, because this is something that I keep saying, is wear a mask if you are able. But we will be having later this week a lecture on ableism. And I think that in that lecture, you will learn more about how limited some people are in their ability to do different things, right? So by and far, most of you probably are able to wear a mask, but there may be some of you who aren't, and it's worth acknowledging that. Now, that doesn't mean that for the people who want to go shopping in the grocery store without a mask on and are using that as an excuse, that's okay, because that's not true. Wearing a mask, provided you don't have a specific health issue that limits you from being able to do so, wearing a mask is perfectly safe. Children under 2 are not recommended to wear masks. Obviously, none of you are children under 2, but you may have seen that in the picture of my niece and nephew, my niece was not wearing a mask because she is under 2. Okay. Yes, you can use information from my slides for your second communication piece. So there are questions about how you will keep distance from your suite mates. Keep in mind that part of the plan for everyone is kind of that you create a bubble and you end up in a bubble with certain people, right? So I've never been in a suite at WashU, so I can't speak specifically to what that layout looks like, but from what I understand, you're going to be kind of put in these bubbles in school, these cohorts of people that you're interacting with as if they're part of your household. And so the rules there are different than when you're interacting with other individuals at large. And another thing that I wanted to point out, and that I think Dr. Jimenez pointed out pretty well, is that there are standards in buildings where they're checking air circulation, they're checking room size, they're doing these sorts of things to make sure that we're using spaces at the university that are safe to have this done. And so, for example, I can think in the anthropology department, there are certain rooms where they have just said, absolutely not. No one can use this room with another person. The ventilation is not good enough. And so, you know, you have people working at different levels to try and make sure that these safety standards are working for us. Okay. So, is it possible that treatment is made more accessible to people of certain demographics? I really like that question, and it's super complicated. On the one hand, you can think like it's a great idea to make sure that people who are most at risk are also the ones who are given the treatment options first. But I also want to point out the fact that historically, we have often used people in those groups as a way to test different types of treatment. And so there is a history to medical work and to this sort of like trying to find new medical treatments that is really problematic and that impacts how we can safely and ethically think about who should be getting treatments at different times. So I don't know that that perfectly answers your questions, but I just want you to be thinking about the fact that this is really complicated, right? We have a history of doing unethical things, and they absolutely impact like how we think about our actions now, and making sure that we're doing this in a safe way that's appropriate for everyone. So there are some questions about the vaccine, and I want to mention that next week we have a lecture by someone who's working on vaccine development, and so I think that will be a great place to ask that question. And I'm continuing to look through these. There's a lot of them. So if things are still being studied, are they safe? That's a great question. I mean, there are different approval processes for getting to be able to test different treatments, right? So they have to go through some level of testing to try and ensure safe treatment before they're given to humans, right? And so I think part of the issue here is that people at large want a quick fix. They want it fast. But the scientific community is trying to balance that with making sure that they're doing all of the safety checks that they need to do so that when you get whatever treatment it is that you're getting, they can be pretty confident that you will have, you won't have any negative effects of that. Okay, so I love this question. The FDA just authorized the emergency use of convalescent plasma, which has shown to reduce mortality by 35%. What do you know about this treatment and its use? Great question. This actually was something that was done in one of the earliest Ebola outbreaks. And, you know, again, this is one of those things where it's tough to know the effects of different factors that were part of patients getting better. So towards the end of one of the earliest Ebola outbreaks that was really largely talked about in Congo back in the early 2000s, some doctors used this method and patients got better, but it was towards the end of the outbreak and it was unclear if those patients would have gotten better anyway because there was already a portion of the patients that were getting better, or if it was actually from that treatment that they got better. So this is an idea that's been around for a long time. It's not something new that's just for COVID. And there's reasons to believe that it could work, right? But we are still not totally sure how immunity works with COVID, which absolutely is relevant when we're thinking about this sort of treatment. And so we have to be cautious about that, as well as thinking about how this could be applied more largely and how long it will take to have the data to know if it really is a safe and effective treatment. Okay, so with that, I'm actually going to wrap up that topic because we are ready to head into our second hour with our guest speaker. And so it is now 2 o'clock, and it is my great pleasure to introduce Dr. Utibe Essien, who is at the University of Pittsburgh School of Medicine. He's going to be talking to us about health disparities and practicing medicine in the age of COVID. So welcome, Dr. Essien.
Thanks so much for having me. I'm going to share my screen with you all, and really grateful for the opportunity to kind of present on this really important topic. I just want to confirm that you all can see my kind of non-notes screen right now. Perfect. All right, so I will jump right in. So good afternoon, everyone. My name is Utibe Essien, and I'm a primary care doc and an assistant professor at the University of Pittsburgh School of Medicine. And I'm also a health disparities researcher here. Really grateful again for the opportunity to share with you all on this topic. It's a part of the Pandemic Science and Society course this week in my talk titled Health Disparities in the Age of COVID-19.
Sorry, 1 second. I just want to mention that the students are able to see your notes.
Okay, let me
Sorry
see.
about that.
No.
I have the same view as you, so I wasn't sure what they were seeing, but I'm getting that comment in the
Let me
for those of you who told us.
Swap that a little bit. What about now?
How's it now? Raise your hand if it's good. How about that? Okay, yeah, it's great. There's hundreds of people raising their hand.
Of raised hands. I can almost see my screen. All right,
Thank
perfect.
you.
Yeah, there really are like several raised hands. All right, so the goals for the session, we're going to describe the data on disparities in COVID-19. We'll examine the disparities in COVID-19, some of the drivers of those disparities, and lastly, we'll identify strategies to be able to reduce disparities in COVID-19. So let's jump right into our first point. So with all my health disparities talks, I always like to start with this quote from Dr. Martin Luther King Jr., which says, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And I think this quote is so powerful because though it was given way back in the 60s, almost 50 or over 50 years ago now, honestly, those words could still be written today. And I often wonder, what would a 92-year-old Dr. King be wondering as he looks at the state of our American healthcare system today? You know, I often also think it's important to bring disparities close to home and not see health disparities as an issue happening out there, but something that's happening right in our backyards. And I was able to do that with this figure from St. Louis, where I suspect many of you all are listening from today. And this figure shows the life expectancy in two varying zip codes in St. Louis, one at the 63105 zip code, which is predominantly white and has a life expectancy that's nearly 20 years higher than the 63106 zip code, which is predominantly African American. And you know, when I had shown you a slide of Pittsburgh, Pennsylvania, where I'm based, or Boston, where I trained, or New York City, where I grew up, unfortunately, those figures and those numbers really would be the same. And so, you know, we've been improving over the years in these data, and as you can see from this figure from the Centers for Disease Control and Prevention, things are getting better. But unfortunately, the fact remains that Black Americans in our country are more likely to die and at higher rates than other racial groups in the United States. And so honestly, it was of little surprise to those of us who are working in the health equity space when the data related to COVID-19 and racial disparities started to slowly trickle in. The early data from Milwaukee to New Orleans, from Chicago to St. Louis really suggested the same, that Black Americans were dying at alarming and far higher rates than other racial groups across the country. Those data really were striking once I saw them come out of the city of St. Louis. And again, this was an article published back in April that suggested that all 12 of the first COVID-19 deaths were Black in the city. And as these data slowly started to trickle out, it really was surprising that many were voicing alarm and concern and wonderment about what was driving these disparities. Unfortunately, those disparities have persisted since that report came out in April. And this is a figure from the American Public Media Research Lab that shows just last week the data related to deaths in COVID-19. And you can see on the graphs that the Black Americans, who make up the green bar here, are dying at the highest rate of other racial groups. And you can see that it's at nearly 2.5 times the rate of their white counterparts, who make up the dark blue bar on this graph, just published out last week. Again, showing the persistence of the racial disparities in this global pandemic. The medical literature has quickly taken up the pace related to these disparities. And while at the start of the pandemic, it was the journalists who were really driving the narrative related to COVID-19 disparities, and the medical journals are starting to pick up these data, including a recent publication last week in the Journal of the American Association from Essien health researchers based in St. Louis, who showed similarly striking differences between Blacks and whites who were admitted to the hospital for COVID-19. This other publication from the New England Journal of Medicine on the left was another report out of New Orleans that showed similar disparities. You know, the COVID-19 disparities are not just a Black and white issue, as these news headlines show from San Francisco, suggesting that near at the top of the pandemic, up to 80% of the individuals who are hospitalized for COVID-19 came from Hispanic groups and Latin American groups in their city. Similarly, in Navajo Nation, American Indians across the country, in New Mexico, Washington State, and Arizona, are also noting alarming rates in that population as well. Again, reminding us that the racial disparities are not just Black and white, but really being seen across various racial and ethnic minority groups in our country. Again, I think it's really quite important to make sure that we realize that the disparities are not just happening out there, and bring in the disparities happening in our backyard. And so this is a screen capture of the COVID-19 dashboard put out by the Open Data Lab in St. Louis. And it's a busy slide, but I want to focus on the racial disparity difference being reported out in St. Louis related to COVID-19. And when we zoom in on those data, we see that Black Americans are infected at 4 times the rate of white Americans in the city of St. Louis. And notably, other data suggests that Black Americans are dying at up to 2 times the rate compared to their white counterparts in the city. Again, really alarming and striking disparities locally and abroad that the data, the researchers, journalists, and public health officials are really starting to pay close attention to. And so with that, let's examine the drivers of the disparities in our second point of this session, trying to understand exactly what is causing those really striking gaps. So this is the framework that I've been using over the last few months to try and understand what is really going on related to racial and ethnic disparities in COVID-19. And as we've been in the country really ramping up our attention to health equity in COVID-19, I present these 4 steps for the way that will guide us through the rest of this part of our session. And so these steps include risk factors for COVID-19, both clinical and social risk factors, access to care from insurance access all the way through to treatment for COVID-19, missed care and how the COVID-19 pandemic has influenced or impacted non-COVID related disease, and lastly, the post-COVID-19 era, and what will that world look like on the other side of this global pandemic. So let's move on to our first step, which is the clinical risk factors. So as the data came out from China and from Italy related to the COVID-19 pandemic, there were a few things that really stood out. One was that there are certain diseases that were more likely to be associated with severe infection from COVID-19. Those diseases included hypertension, diabetes, obesity, and chronic lung diseases such as asthma and COPD. Those diseases, unfortunately, as the slide on your screen represent, are far more common in racial and ethnic minority groups, and in particular, Black Americans, who have across all ages higher rates of diabetes, higher rates of high blood pressure, and higher rates of other cardiovascular diseases. These higher rates, unfortunately, have been one of the key reasons putting this population at high risk of COVID-19 infection, and especially severe infection and death. Along with the clinical risk factors, and even conjoined with the clinical risk factors, are the social risk factors, and this new idea of essential workers being potentially overexposed to COVID-19. This is a national report out of a city in Chelsea, Massachusetts, where I had my primary care clinic during residency training, that reported that in this immigrant community, essential actually meant vulnerable. And over the last 5 months, we've really seen that definition of quote unquote essential workers vary as we started to see individuals who are delivering our food, delivering our mail, working for other rideshare services and in roles that have continued to be essential over the pandemic really come from these same racial and ethnic groups that have been hardest hit by the COVID-19 pandemic. This idea of essential workers has really led us to ascribe to the mantra that social distancing is a privilege, as those of us who have had the opportunity to work from home on a screen like I am with you all today have certainly been underexposed to the pandemic compared to our colleagues who are out, quote unquote, on the essential front lines. I really think it's important to think about this population in need. Along with the essential workers being a at-risk population, it's really critical and important to think about the environment and how the environment has potentially put individuals at higher risk of exposure to COVID-19. This is an article published out by St. Louis Public Radio back in April, suggesting that individuals with polluted air have been more vulnerable to the coronavirus, and that vulnerability is due to polluted air resulting in higher rates of chronic lung diseases, such as asthma and COPD, as we mentioned. Unfortunately, in our country, as St. Louis really has been exposing us to, the racist history and policies related to housing, such as redlining, restrictive covenants, and other discriminatory practices have really resulted in certain populations, in particular Black, Hispanic, and Native Indian American populations, residing in communities that are at higher risk for pollution and therefore at higher risk of exposure to COVID-19. There are a few other really critical at-risk populations that we need to pay attention to. One is the prison population. This group of individuals who are incarcerated, who have poor access to soap, poor access to water, and certainly poor access to be able to socially distance, as public health officials have continued to warn across the country, has been in particular high risk across the nation, from New York all the way through cities and states across the South. This population has really been experiencing increased risks and rates of COVID-19. Along with the prison population, it's important to think about the homeless population and how they have been at risk. And this paper published in the Journal of the American Medical Association showed that a shelter in Boston, Massachusetts had a 36% positivity rate for COVID-19, up to 30% higher than the 6.5% positivity rate that the entire city was experiencing. Again, a population with limited access to soap and water, limited ability to socially distance. And lastly, thinking about the immigrant population, this study published out of the Bronx, New York, really showed that that population, due to fears of presenting to the clinic with symptoms, just as doctors have been suggesting, because of their immigration status, or those who have been detained having, again, high-risk exposures because of the close confines that they've been residing in. So I really want us to think about these at-risk populations, along with the essential workers, along with those who have been at clinical risk for COVID-19, as some of the key drivers of COVID-19 and its disparities across the country. And so that will take the next step across our framework up to the access to care step. And so when I think about access to care, really the first thing that comes to mind to me is the fact that in 2020, there still remains 27 million Americans who do not have access to insurance. As these data show from the Kaiser Family Foundation, which is leading health news reporter. These populations are predominantly Black and Hispanic, and these are the folks who continue to unfortunately have poor access to healthcare. The folks who, as public health leaders have been calling it, are actually underprotected from COVID-19 because of that. Not only is insurance an issue related to access, but unfortunately, as we think about testing, which some have deemed the quote unquote original sin of America as related to COVID-19, we've also seen significant and really stark health inequities related to access to testing, as these news media headlines show. Back in May, there was an article in the National Public Radio that suggested that hospital and non-hospital testing sites in Texas were far more likely to be placed in majority suburban and white neighborhoods compared to poorer minority Black neighborhoods. Literally, the physical ability for individuals to be able to access testing has been inequitably placed across the country. And as this headline from April suggested, the coronavirus does not discriminate, but the US healthcare was showing familiar biases, in particular related to testing. As we continue to think about testing and the inequitable access, unfortunately, till just a few weeks ago, there are only 4 states in the country, including Nevada, Kansas, Illinois, and Delaware, that are even just reporting race and ethnicity related to testing of COVID-19. These reporting are so critical because if we don't know who has COVID-19, we're not going to be able to know where to distribute our resources, and in turn, how to be able to even prevent the disease as we think about vaccination far down the line. So again, another step in the road towards really being able to address these disparities is actually just knowing the data and having those key data, especially related to testing for COVID-19. So along the access step of the framework, I think it's important to think about who is actually being admitted, and when they get to the hospital, what does their care look like? This was an article in the New York Times published back in April that did a whole report related to access to interpreters and translation services for at-risk individuals for COVID-19. This report came out of the hospital where I trained in Boston and found that up to 40% of individuals who were admitted for COVID-19 at that time were Hispanic, and 80% of that group were Spanish speaking. As we know, 5.8% of all doctors are Hispanic in our country. And so we can only imagine what that mismatch looks like in a hospital where patients are really isolated. They don't have their usual family member there to interpret for them, don't have their usual advocate, and have to deal with either ensuring or accessing translators, using iPhones or Samsung devices to make sure that they get the translating resources that they need, and just how challenging that might be, again, in the middle of a pandemic. And so along with insurance, along with testing, I really think that just literally being able to speak to our patients is a really critical aspect of access to care. And lastly, when our patients get through the hospital, so they have insurance, they're able to show up and get the care that they need, they speak the language of their provider, this issue of whether they can actually access the critical treatment that they need is hugely important. And again, this was a New York Times piece published back in April when many of us were really worried about what rationing of resources were going to look like. Back in April, there was a fear that we would run out of ICU beds, run out of ventilators. At one point, we were fearing running out of dialysis machines rather, and running out of even treatment, the very treatment for COVID-19. And unfortunately, research continued to show that Hispanics and then Black Americans are less likely to get access to treatment, even when they're in the ICU, to get access for that critical treatment. And so many of us, again, who are working in the health disparity space are really working to ensure that patients have the access to care that they need, whether it's a ventilator like the woman on the screen is symbolizing, or it's the newest treatments like remdesivir, which has been shown to decrease your ICU stay, or it's even the vaccines that are now starting to be touted around, like, are being moved on through phase 3 trials. How do we make sure that these critical life-saving resources are being extended to the populations at highest risk is what many of us are really working for, and unfortunately, what was not necessarily prioritized back at the start of this pandemic. And so we'll keep moving along on our steps of the framework for COVID-19 disparities, and we're now at the missed care step. And in the missed care step, really, it's this really interesting piece that came out again in the New York Times. I'm really focusing on the work of journalists because they have really been driving, again, this conversation related to disparities. And one of my colleagues published in this newspaper an article titled, "Where Have All the Heart Attacks Gone?" And in this article, they noted that up to 40% of hospital admissions for strokes have decreased over the last 5 months, and up to 50% of hospitalizations for heart attacks have decreased over the last 5 months. I think understandably, the world has just not gotten healthier over the last 5 months, but we can only imagine that patients are either for fear of showing up to the hospital and potentially getting sick, for fear of being pushed away or sent away from the hospital, or that they're possibly even just dying from COVID-19, that we've really started to see a drop or a miss in care for patients who have other non-COVID related diseases. And this paper just kind of suggests what I was reporting there earlier, with a 40% drop in critical care transfers, so patients aren't actually being sent on the ambulance over to the hospital, that drop in strokes that I mentioned, and the nearly 50% drops in heart attacks is that number that I mentioned there as well. You know, one of the big reasons that we're seeing this difference, one of the big reasons that we're believing is related to this opportunity for patients to actually be able to access their doctor. I mentioned that at the start of the pandemic, one of the big public health claims was ask your doctor about your symptoms. Tell your doctor what symptoms you have. And we can only imagine who actually has the access or who actually has the opportunity to do so. As hospitals, rather healthcare and tech workforces were starting to shut down, along with schools like last year, hospitals and primary care clinics are doing the same. And we've all made this transition towards seeing doctors as in the same way that you and I are seeing each other today over a screen. And we can only imagine what that means for individuals who have limited bandwidth, who have limited internet access and limited internet service, if they're able to, again, actually just be able to engage with a doctor over the last 5 months. And so we truly believe that this was one potential reason why we're starting to see an increase in what we deem missed care. And so finally, we're at the last step. Our little man is at the top of the journey here for our framework for COVID-19 disparities and thinking about the post-COVID-19 era. And so honestly, the very first thing that I think about when I think about a post-COVID-19 world is related to jobs. Job loss, which has been completely and historically experienced over the last 5 months, with nearly 20 million individuals experiencing homeless or unemployment over the last 5 months alone, has really significant downstream effects in our health. You know, job loss results in lower income. Job loss results in lower access to insurance, which we talked about is such a critical need in patients actually being able to access a doctor. Job loss results in poor access to housing, which can really, as we saw, increase one's risk for COVID-19, just literally having to reside in a shelter. Unfortunately, job loss has been disproportionately impacting racial and ethnic minorities. And as this Washington Post article shows, Hispanics were twice as likely as white Americans to have lost their jobs during the pandemic, with Black Americans really following shortly after. And along with the post-COVID era and joblessness, I think it's important to think again about the digital divide and its impact from COVID-19. As you and I are experiencing school via a virtual platform, again, we can only imagine what our high school, middle school, and elementary school colleagues are experiencing across the country, or peers. what school looks like for individuals who don't have the same access, again, to internet services, to education services, to broadband like you and I do today. And just years lost of education can literally impact one's health down the line. Education has close impacts with diabetes outcomes, with heart attacks, with high blood pressure, and with higher weights, all of which end up putting individuals at high risk for cardiovascular disease, which, again, as we're seeing in this pandemic, really does unfortunately disproportionately impact certain populations. And so we've gone through the various drivers of disparities. We talked about the risk factors, both clinically and socially. We talked about access to care. We talked about missed care. And we've touched on the post-COVID-19 era. So now how about we identify some strategies to actually address these disparities in COVID-19? And so many of my colleagues have been writing about this topic over the last 5 months. And I'd love to share some of these references and resources with you all. And I can tell you that all of what I've been talking about over the last few slides, as well as what we'll discuss moving forward, really comes from a lot of these folks who are leaders in the health equity and health disparities field. And so along with these folks, my colleague, Dr. Venkataramani, who's a health economist, and I also had a publication written up in JAMA Health Forum, talking about some potential data and policy solutions to address racial and ethnic disparities in the COVID-19 pandemic. And so I'll share some of those steps with you all, or solutions, in this 5-step plan that I have, which again is in no way comprehensive, in no way captures everything that I think we can really do for this moment. And I'd love to hear some of you all's thoughts as we go through the Q&A on the other side of this talk. But the first solution and the first step that I have for us is really enhancing race and ethnicity data collection. I mentioned to you all earlier that only 4 states a couple of weeks ago were reporting race and ethnicity related to COVID-19 death, or testing rather, excuse me. In a study that my colleagues and I published back last month, we found that only 28 states were reporting race and ethnicity related to death. And of those 28 states, there was a huge variation in how much data was missing, with some states, including Pennsylvania, where I am, missing as much as 40% of those data. So you can only imagine that potentially we're actually underestimating the disparities that we're seeing related to COVID-19 across the country. So back in 2010, the Affordable Care Act made the collection of race, ethnicity, and language data federal law. They made it a mandate that hospitals receive federal funding have to report these data. And so 10 years later, this isn't a new policy, this isn't a new process. We have to be able to really do a better job at collecting these data. And so my second step is going to be related to expanding access to healthcare. And while many of my colleagues suggest that we have universal healthcare coverage that makes sure that every American has the same kind of access to healthcare, and I think that's hugely important, but I do think that we have to start with what we have access to right now, and that's Medicaid expansion. So expanding healthcare to the states that don't yet have that expansion, especially for the most vulnerable populations, unfortunately, who are the poor, low-income populations and racial and ethnic minorities. And really awesome to see that Missouri made that expansion just a couple of days ago. So really excited to see what impact that has on health outcomes moving down the line. I'll also say along this point that my hesitation to promote universal healthcare is that as we look across the pond towards the UK, we actually see the same exact disparities. There's a paper that came out from the CDC that said that 33% of hospitalized patients were Black with COVID-19 compared to 13% of the American population. And then when you looked across the pond to the UK, literally the numbers were exactly the same. 33% of their hospitalizations were from Black, Asian, and multi-ethnic groups compared to the smaller subset of their population. So it's really not just a universal healthcare issue, and we really have to deal with some of the root causes of disparities in our countries. And so some of those root causes really have to do with how we're innovating around testing tracing, and treatment of COVID-19. And making sure that across all those 3 T's, like many of us in the public health field are speaking of, that we have and ensure that equity is at the forefront of that entire process. Second to last step here in our 5-step plan is, I think, the most critical step. And that may not have to do with what I'm doing as a physician on the day-to-day basis, but really what public health leaders, what education leaders, what policymakers can start to do, and what young people across the country, I believe, are really starting to advocate for, is eliminating discrimination, eliminating racism, to call it out, in housing, in education, in employment, in immigration, and across the justice system. I showed all of those at-risk populations earlier. Our homeless colleagues and peers, are those who are struggling with the digital divide and access to education, how immigrants across the country are really struggling with COVID-19, and our incarcerated fellow Americans. And so those populations that are highest risk are, again, disproportionately coming from racial ethnic minority groups. And if we really start to eliminate discrimination in the policies that put individuals in this place, I believe that we can deal with some of the disparities we're seeing in COVID-19. And lastly, as health systems and as those who are thinking about health careers, we really need to invest in our community and our social services. And I think that this point is so critical. And it really means that rather than just putting resources and dollars into hospitals that are taking care of sick patients, that we actually go into the neighborhoods, go into the communities, go into that members in that 63106 zip code to invest, again, in schools, invest in communities, health centers, invest in churches, and invest in other resources that can really benefit the community. Resources that a community can trust, so that when vaccines are coming out, again, I'm harping on that because of how challenging it is for people to even come to the doors to get vaccinated because of all the distrust in our healthcare system. But when across all the steps of this COVID-19 crisis, I really believe that our community partners are far more better equipped to help us address some of these disparities that we're experiencing today. And so that was my 5-step plan. Again, I'd love to hear from you all what suggestions that you might have for some of the solutions. One of my colleagues in the American Black Cardiologists Society actually published in one of their journals a disparities and a solutions slide. And I wanted to share that with you all today as we go forward, because I think it's a really beautiful and comprehensive view of everything that we've talked about today. Again, we've shared on the left-hand side the disparities that are driven both by disproportionate burden of clinical comorbidities, poor access to care, and social risk factors. We also talked about some of the challenges with unemployment, and again, in my solutions slide, I touched on how discrimination really plays an important role. And on the solutions side of this slide, on the right-hand side, it really touches even beyond some of the steps that I talked about on my solution slide, talking about expanding housing and providing food to individuals who unfortunately lost their jobs and lost their main source of income and are really having to depend on our social network, on our social safety net to help and meet them at the point of their everyday needs. We talked about expanding healthcare coverage, how we can help support education, especially related to the internet access. This point around protecting workers, I think, is hugely important. And one slide that I didn't show you all is a recent study that came out to show that individuals who are working in minority communities have been more likely to actually themselves get COVID-19. So these frontline workers, from nurses to physician assistants to physicians themselves, both in the US and in the UK, who are minorities and working in these communities, have had higher rates of COVID-19 themselves. And so how do we make sure that we're protecting our frontline workers, especially as we think about future waves of COVID, is really going to be critical. And again, I touched on partnering with our community members. I touched on some of the policy initiatives that we need to address in this time. I didn't really touch too much on transportation, but I think that that's a hugely important step as well as we think about where testing sites are, again, how those are disproportionately located in certain communities, making sure that our patients in need who potentially reside at faraway sites can actually access those testing sites. And so that's why I believe transportation is really important. And again, testing. If that's one thing you can take away from this slide, from this talk rather, it's how critically important testing is and how we have to do better and making sure it's done so equitably. So as I get closer to closing out, I wanted to touch on the 4 waves of COVID-19. And this is a slide that has been kind of making its way across social media related to how COVID-19 is really going to be affecting all of us. How, although it was once deemed a great equalizer, we've clearly seen over these last 30-something slides that COVID has been really disproportionately affecting certain groups. Unfortunately, the very waves of COVID-19 are affecting all of us as a country and globally as well. The first wave touches on the immediate mortality and morbidity, as we're sadly closely approaching 200,000 deaths from COVID-19. We saw how that quick fear led to us shutting down quickly and closing restaurants and bars and schools and workplaces, as we had to really quickly deal with that quick illness and death that was being experienced back in March, April, and May. In the second wave of the COVID-19 crisis, we see the impact on resource restriction. And so I talked about how we had this question, where have all the heart attacks gone? And so not only were patients just not seeking care, but in some cases, it was actually just hard for patients to access care. I have patients who said, well, I didn't know if my doctor was open, doctor's office was open, and so I just stayed home, or I didn't show up at the urgent care because I didn't have a mask and I wasn't sure what the policy was there. And all of these kind of challenges that are happening internally that really potentially have an impact on the access and future outcomes for patients all across the country. In the third wave, again, that interrupted care of chronic conditions, as you just talked about, whether it's cardiovascular disease or it's actual cancer screening. So one thing I didn't specifically touch on was that hospitals were not just having virtual visits, but they're actually canceling non-elective procedures. And so potentially cancer screening procedures or surgeries that individuals said that they had scheduled months in advance were being canceled because they were deemed non-essential or non-emergent. And so unfortunately, there are still patients kind of sitting around with their chronic knee pain, wondering when they're going to have their colonoscopy or their mammography because of this interruption of non-COVID related care. And lastly, and really importantly, thinking about the fourth wave of the COVID-19 crisis, the trauma that our communities are facing due to all the death and illness in those communities, both the patient side and on the frontline provider side. The mental illness that's coming down the line, whether it's from isolation due to having to socially distance or quote unquote quarantine, like many have been doing over the last 5 months. And we touch deeply on the economic injury that are being experienced related to post-COVID job unemployment. And lastly, just burnout. Many of my colleagues who were working in some of the hardest hit cities like New York City and Boston were really struggling at the tail end of the pandemic with the day-to-day work, just having to wear gowns in every clinic, having to wear the N95s. We've probably all seen the images of mask scars from frontline workers across the country. And so again, as we think about this COVID-19 crisis and think about the disparities in it, I do want us to continue to consider how both early on in the crisis, I showed a lot of data from April, but also as we move along towards the fall and thinking about schools and the flu pandemic and the flu season rather, and all the other stages, that we continue to put disparities and put equity at the front of our mind. And so I really will be remiss if I didn't touch on how racism has really amplified the COVID-19 disparities crisis right now. As many of us were thinking about how COVID was affecting the populations that we come from, our families, our friends, and our peers, we had the unfortunate incidences back in May of George Floyd's death. And unfortunately, even more recently, of Jacob Blake's shooting just a couple of days ago. As this slide shows, there are thousands, millions of young people who are going around the country, just as they did 6 years ago when I was a resident and training and was hearing the calls for advising and treating racism as a public health issue when Eric Garner died, after Michael Brown died, unfortunately near where some of you are located today. And so 6 years later, from those moments, this call is still as loud as it's been before. This call, I truly believe, is a big part of the COVID-19 disparities. Again, racism driving where people live, how people work, where people are currently situated right now in their lives, and how that has been increasing their exposure to COVID-19. And both professionally and personally, this racism as a public health crisis has been impacting me. And I imagine so many of you all on the call today. And while I do hold out hope that this moment will be different, I certainly do bear it with caution, hoping and believing that the more we talk about it, the more we call these issues to attention, the more our communities will continue to wake up to this issue. And again, my colleague so beautifully said it in one of our medical journals just a couple of weeks ago, that the response to the pandemic has made at least one thing clear. Systemic change can, in fact, happen overnight. And so while it may seem like things are difficult, hard, and impossible, our country was able to stand up millions, billions of dollars of resources to be able to get through the pandemic, build coronavirus wards, provide payment protection plans to millions of Americans across the country. And so I do believe in the same way they were able to respond to that, they will be able to respond to these twin pandemics of racism and the COVID-19 disparities. And so with that, I really appreciate you all's time and attention, and I look forward to taking any questions that you might have. Thanks so much.
Thank you very much. That was wonderful. And the students have hundreds of questions, literally. So I've tried to pare them down to a few topics. And I want to say thank you so much for including the specific information about St. Louis in your talk. One of the students sent in a note saying that they are actually conducting research about healthcare in North St. Louis, which is one of the zip codes that you pointed out, and that it was really great to see this lecture, and thank you so much for providing this lecture. Another student mentioned that it was worth pointing out that the WashU dorms are in the other zip code that you highlighted, which is the predominantly white zip code. So I think that personalization of the data was really helpful. So thank you for that. I think students have questions around a lot of different areas. One of them is that a lot of the advice that you gave about how we can move forward from this are things that they feel like the government needs to do. So they're wondering if you have any advice for them on what they can do as students in their day-to-day lives and conversations, or in the positions that they're in, to try and dismantle the racist healthcare system and deal with these disparities.
That's an awesome question. And while I was able to individualize the talk mostly around St. Louis, I do appreciate that I didn't quite practicalize these steps for folks at you all's level. And I think first thing is advocacy. Again, appreciating that advocacy can happen at any age and at any stage of your career, whether it's via social media, by writing to your Congress people, your senators, by penning op-ed pieces. I believe the voice of students like yourselves at this incredible institution that I really hoped to get into for medical school one day, but I didn't get an interview, but it's all good, will really mean something to have your voices say, look, our dorms are in the one of the highest life expectancy. Just me literally maybe potentially residing here over these 4 years is actually going to improve my life expectancy compared to my peers just across the way. And so I think using your voice in that way is really meaningful. Learning the history, I think, is so critical. I have a couple of these books here on my screen, including The Color of Law and The New Jim Crow, which has taught me so much about how residential segregation and how incarceration has completely blown away racial disparities in our country. I spent 12 years learning how to be a doctor, being pre-med and going to med school and doing a research fellowship. But it wasn't until the last couple of years where I really tried to dive into understanding and learning about race and our history of race in this country that I realized how little what I was learning during medical school really mattered, and how much the 1930s policies, again, around redlining and restrictive covenants meant to my patients in the Bronx and in Boston, where I was training, and how much the literally just all of the housing policies, really, how much the war on crime meant for the disparities in incarceration in our country, and why, again, people who look like myself are just far more likely to be incarcerated, not because they're worse people, not because these are bad neighborhoods or anything, but again, just because of policies that are in place. So I think learning that history is really critical. So those would be two steps: using your voice and continuing to read up, that I believe can be some practical steps to help along the way.
I think that's great. And I appreciate you referencing your own experience, because a lot of the students have questions about that, what it's like for you as a healthcare provider and as a Black person, like how that impacts your experience as a healthcare provider, and also what it's like in medical school when you're learning from textbooks that so often have pictures of white patients and things like that.
Yeah, that's really coming into favor. So I'll give a quick plug to folks, if that's okay. We have a really amazing anti-racism in medicine series. And so I think I could put it in the chat probably, the link for this. And so this series is really going to touch on those very points. So how can we, in the medical field, really move to understanding and appreciating how race and racism influences the care of our patients, and how race and racism influences our roles as doctors as well, or as healthcare providers. So physicians, nurses, again, all across the bandwidth, and as researchers as well. As someone who's kind of wearing all of these hats, the COVID-19 pandemic has really just called them out. So back in May, the news reporters were starting to ask me, well, how can you feel comfortable with your peers going out and protesting when you just told me that I should be social distancing, wearing a mask, and not going out to protect myself from COVID-19? And so folks are almost asking me to make this crazy decision to either fight for the lives of myself and my siblings and my fellow colleagues of color, or to fight for a pandemic that was disproportionately affecting myself, my siblings, and my fellow colleagues of color. And so really, being Black in this country is so challenging. You can't really go on a day-to-day basis without experiencing some slight, whether it's a personal microaggression or a macroaggression related to the violence that we see in our country. And so this link that I have up here, the Clinical Problem Solvers, is we have a new series, an anti-racism in medicine series. And the first episode comes out tomorrow, and it's called Racism, Police Violence, and Health. And unfortunately, it's really painfully timely related to the events of this week. And I hope it really touches on some of those questions, what it's like to be Black as a physician, as a researcher, and as someone who's just living in this world related to COVID and even beyond COVID-19 as well.
Thank you for sharing that. That's really helpful. And we'll definitely share it on our Canvas page as well, just in case any students didn't get it. So related to that, students are wondering, given the history, and I actually touched on this a little bit in the first hour, but a lot of students had questions for you about it. Given the history of using marginalized groups for experimentation in medicine, how do you balance that with the fact that we want to make sure that these populations that are most affected by this disease get treatment as quickly as possible, but we also don't want it to fall within that problematic history?
For sure, that's a really important question as well. And my colleagues and I are really trying to think about this so deeply. So my colleagues and I have a group text, and many of us have said, well, I'm not going to go be first in line rather for that COVID vaccine. I'm going to let Dr. Fauci or someone else be one of the first people to get vaccinated because, you know, we literally have the fear of what that looks like. And we can only imagine folks who continue to hear disinformation or receive disinformation, maybe don't have as much health literacy as those of us who are being professionally trained in the field, what it may mean for them or those who literally their communities, their siblings, their parents, folks just a generation or two away were affected by that 40-year Tuskegee study that literally just ended in 1972. And so this history and legacy, unfortunately, of distrust in America is so wide and so rampant, especially around communities of color. And so it really is hard for me to say, you know, get out there front in line and go get your vaccine, go get your new, you know, untested treatment for COVID, when I can just completely and fully appreciate why folks would be hesitant. I do think it's on us as a health system and as public health leaders to be trustworthy and gain that trust. You might think, well, Tuskegee was 50 years ago, you know, quote unquote, get over it, but it was just 50 years ago. And how can we get over something as painful and difficult as that, right? And so we have to continue to build up trust with the community. I think that is working with community members, and not just in name and saying, hey, I have one community partner, I've done my job, I can check off that box, but really doing the hard work of going out into those social and connecting with those social groups that really know the community far better than we do, and being able to understand their fears, their doubts and worries, and figure out from them how we should help build that trust rather than us just assuming the paternalistic measure that many of us in healthcare do, that they deserve our trust.
Yeah, exactly. Very well put. Related to that, so you mentioned that there are these issues of not knowing the racial breakdown of individuals being treated and whatnot. Is there concern over privacy? Are there reasons that people wouldn't want to report that for privacy reasons?
Yeah, really great question. And that's one of the reasons that I've been giving around why, at least early in the pandemic, there was some hesitation about reporting those data, because, you know, if there are 3 African Americans in your county and 3 of them are, you know, Joe, Sam, and Sue, and you know them, you know the 60-year-olds, you start to really break them down by zip code, by age, by race and ethnicity. Things might get a little tricky there related to privacy, right? And so I think at the start of the pandemic, that was certainly a fear. Unfortunately, we are millions of cases in now, and across the country, not just in large urban cities, not just in red or blue states, quote unquote, it's all over. And so I think the privacy issue is not as much of a challenge now, especially unfortunately as the cases are rising. But that is the responsibility, again, of the federal government and of the healthcare system to make sure that privacy is protected, to make sure that at the most granular level of data, that patients are still being protected, especially related to their privacy. So names, social security numbers, all of that information should in no way be extended to the federal government related to illnesses and sicknesses. And that's, again, on us as a public health field to continue to express that to the public.
Yeah, can you also just talk a little bit about how poverty and race, like, to what extent are the issues, like you pointed out these issues around St. Louis, but students also were wondering, what about the outcomes are related to poverty and what about the outcomes are related to race?
Yeah, so this is another area where I've really tried to push that poverty and race and socioeconomic status are completely different measures, right? And so several studies continue to show that regardless of your income status, regardless of your social class, if you're African American in this country, you are more likely to die. You're more likely to die at a higher rate. I can be the most wealthy African American, and this is really what got me into this research, is seeing a study that showed completely different graphs if you were African American or if you were white, based on your income status and based on your life expectancy. And that just didn't make sense to me. I figured, get your education, go to college, get a good degree, get a good job, get a good income and wealth, and you'll be fine, check off these boxes. But data continue to show that that's just not the case. And so I think we have to be comfortable pushing the envelope and saying that race is a key measure of health disparities in our country, and more specifically racism. Racism is the reason that once I take off this blazer and bow tie, that people will just see me as quote unquote another Black man. And if I show up at the hospital and don't have my ID, don't have my stethoscope on my neck, people are not going to treat me in the same way that they would if they saw me otherwise. And so unless we feel comfortable appreciating that specific driver, I do feel like we're gonna be stuck in the same places that we've been over decades.
Yeah, thank you. So we are actually running out of time, so we need to wrap up, but I just wanted to give you the chance, if there's anything else that you want the students to know as we head back into this semester, any words of wisdom that you have for them.
Well, I really hope that this was a useful course and a useful talk. I really just want to continue to encourage you all to learn the history. And again, thank you, Dr. Milich, for putting up this course and allowing us to learn some of that history through these 3 weeks. Continue to realize that a lot of this is not new. In the 1918 flu pandemic, we saw very similar disparities. In the 2006 H1N1 pandemic, we saw similar disparities. And so, unfortunately, we don't have to reinvent the wheel. Looking back to history really does guide us with a lot of resources.
That's super helpful. Thank you so much. This has been a wonderful presentation. I really appreciate it. Thank you.
Awesome. Thanks so much.
Yep. All right. Have a good day. And thank you again to everyone else. We will be back here tomorrow. Until then, stay safe.